Good evening, all of you. So today we welcome Dr. Bertie Surgith Fernando, who is currently a consultant at East Lancashire Hospitals. So after graduating from Chennai, Dr. Fernando completed his diploma in ophthalmology at Arvind Eye Hospital, Madurai, following which he underwent senior house training at North Middlesex NHS Hospital, London and Manchester Royal Eye Hospital. He then underwent a one-year oculoplastic, tracheal and orbital surgery fellowship at Brisbane, Australia, and another one-year fellowship at in oculoplastic and orbital surgery in Manchester. He specializes in managing patients with periocular tumors and lid malpositions, apart from treating patients with thyroid eye disease. Thank you, sir. Over to you for your talk on thyroid eye disease, sir.
Thank you, and good afternoon to everyone. So today's talk is, I should thank Dr. Venkatesh and Arvind Eye Hospitals for inviting me to give this talk on thyroid eye disease. Is it a pain or a pleasure? Well, is it a pain for the patient? And is it a pleasure for the treating physicians? I'm not sure how many of you are out there who can confidently say that they are happy with dealing with thyroid eye disease. Now, what this lecture is going to be, considering I'm going to speak for only for the next 40 minutes, is going to help you build a scaffold on which you can build your knowledge. Now, thyroid eye disease is quite complex. There are different arms to managing these, and it would be near impossible to give you all the nuances with dealing with this condition within 40 minutes in a small lecture. Now, I am going to give you parts of this jigsaw puzzle. It's up to you to make up the scaffold and solve this puzzle. Each patient is unique. Each of them have their own problems, and we have to solve each one individually. Now, if you're very good at solving puzzles, then you will enjoy dealing with this condition. If not, it's very often quite a painful procedure. Now, what is the thyroid? All of us know that the thyroid gland is the largest endocrine gland in the body. It produces thyroxine, and thyroxine is responsible for regulating our metabolism in the body. It affects your brain development, it maintains the bone metabolism, it affects your heart rate, affects your muscular system, and it goes on forever. And that's why it's very important. Now, how does the thyroxine come into your body and how is it regulated? It's a simple negative feedback. The hypothalamus produces the thyrotropin releasing hormone, which in turn stimulates the anterior pituitary to produce the thyroid stimulating hormone, which in turn stimulates the thyroid to produce thyroxine. Thyroxine in your blood is converted in the peripheral tissues, and if you have enough thyroxine, there is a negative loop which stimulates the hypothalamus or inhibits the hypothalamus from producing thyroid releasing thyrotropin hormones. Now, what happens if you don't have enough thyroxine in your body? You start having problems from your hair, you start having eye problems with your skin, problems with your heart, problems with your gastrointestinal system.
Sir, excuse me, sir. I think the audio, there is some echo, sir. We are not able to hear clearly.
Do you want me to start all over again, or?
No, from this slide, I think there is some echo from your side, sir.
From my side, I've switched off all the mics here. I've switched off my phone.
No, it's clear to us. It's clear to us.
Okay, sir. We'll proceed.
Okay. So in terms of thyroid dysfunction, you have significant problems based on what symptoms you have. It's kind of an educated guess. You don't need to have significant problems. You don't need to have significant investigations, and you can have a guess on whether it is an overactive or an underactive thyroid. Now, we are not here to talk about all the causes for primary thyroid disorders. We're going to concentrate on only one, the primary excessive production. And the main reason for this excessive production is an autoimmune pathology. Autoimmune meaning there are antigens which stimulate the thyroid gland. The antigens, the most common antigens are the thyroid receptor antibodies. The second most common is thyroid peroxidase antibodies, and after that is the thyroglobulins. Now, we are going to park this knowledge to one side, and the incidence of Graves' hypothyroidism in a general population in the Western world is approximately 210 per million per year. Obviously, it's more common in women than in men, and the peak incidence is around 40 to 60 years. Now, depending on which study you read, the incidence of Graves' orbitopathy varies from 20 to 30% in the whole population with Graves' hypothyroidism. The pathogenesis of thyroid eye disease is quite fascinating. So every time I read a paper on thyroid eye disease, it is fascinating on the pathogenesis specifically. And by the time I come to the middle of the paper, it does become very confusing. And by the time I finish the paper, it is outright irritating because either you've not understood the whole pathology or you have significant confusion because of this. The main reason why there's been so much of confusion with the pathogenesis is we were unable to create or simulate a rat model with this whole pathogenesis. In the last few years, we have managed to create a rat model, and the current theory is the thyroid stimulating antibodies stimulate your orbital fibroblasts, which produces excessive hyaluron and glycosaminoglycans. Now, this results in the adipose tissues to be hyperplastic and hypertrophic. Now, that is in quite simplistic terms. It's a lot more complex than that. So for those who are really keen on reading the pathogenesis, this is a very good paper, which I've quoted that. Now, the very first person to kind of classify thyroid eye disease was Rundle, and he kind of charted the whole disease process into a biphasic event. So 2 phases, the active phase and the inactive phase, on a simple sinus curve with the X and the Y axis, the X axis resulting, telling us the time, and the Y axis, the severity of the disease. Now, the whole disease process is meant to last between 5 to 7 years, while the active phase is in the first 18 to 24 months. Now, I'm sure all of you have kind of spoken about the various, read about the different stages in thyroid eye disease. Now, we know that we have a person with hyperactive thyroid. We know that there is we want to know who develops thyroid eye disease. Now, when do they develop it? They can develop ocular symptoms up to 12 months before or up to 12 months after a thyroid dysfunction. Who develops these conditions is more common in women than in men. And the risk factors, the 2 most common risk factors are smoking and the thyroid antibody levels in your body. Now, it's quite important that we assess the thyroid eye disease for several reasons. One, we want to know if there is clinical activity, and you want to know the severity of what's happening there. There are different tools to assess our clinical activity. The most common tool is the clinical activity score, and the no-specs classification is for the severity. Both these are kind of a binary tools. So the European group on Graves' ophthalmopathy came up with their own assessment tool. Now, in terms of the clinical activity score, Moritz and her team from Amsterdam kind of came up with the tools. They were on 10 different questions, quite simple questions. You ask the first 7 during the initial assessment, and you follow on with the other 10 questions for the follow-up assessment. So if you scored around over 3 during the initial assessment, you were considered to be active. And if you were more than 4 in the follow-up assessment with 10 questions, you were considered to be active. Now, that was for the activity, and for the severity was the classification where you had the no specs. It's very common in most ophthalmic texts, where there were different groups, up to 6 different groups. Now, both these were binary, and it's not very ideal when you have to deal with the whole disease process. So you want to know the clinical activity as well as the severity of the actual condition for each patient. The reason why you want to know this is you want to chart them on the Rundle's curve, and then you want to assess them before and after treatment. So if you want to know if there's any improvement, you want to know what the score is. If it's actually getting worse, or if there is a recurrence, you want to have a score on that too. Now, at the same time, the UGOGO assessment came out. The UGOGO assessment is quite good, especially for those who are starting off with managing complex thyroid eye disease. It's excellent for the inflammatory tool. So they went on and classified the eye condition into 3 groups. One was mild, the second was moderate to severe, and the third one was sight-threatening eye disease. Now, at the same time that UGOGO came out with this assessment, Peter Dolman and his team in Canada came out with what they call as a VISA classification. V standing for vision, I standing for inflammation, S standing for strabismus, and A for appearance. Now, although Dolman and the team kind of say it's a quick A4 sheet, for those who use this form regularly, if you need to do a good workup on this form, it would take a good 30-40 minutes. There are 2 specific forms, one for the initial visit, and the second one was a follow-up form. Now, the advantages of the visa form, it kind of encompasses both the clinical activity and the severity together. And it's so for those who are starting off, visa form is quite good. Who've already done a fellowship, visa form is quite good, straightforward. For those who haven't done a fellowship, you should combine the UGOGO inflammatory form along with the visa form, and that will give you quite an accurate assessment. Now, in the UGOGO assessment, you have all the inflammatory indices, and if you do score more than 5, you would be considered as an active disease. Less than 5 is less active. Now, anyone with more than 5, you want to be a bit more aggressive with the treatment, and less than 5, less aggressive with the treatment. The whole purpose of this assessment, which it will help you starting off with the steroids at the earlier stage than normal. Now, we have a patient with hyperactive thyroid who develops a thyroid eye disease, and you have assessed him. And the second thing you want to do is the investigations. By the time most patients come into my clinic, they have had all their hematological investigations done. So I don't repeat most of the tests done. If the thyroid antibody levels are not done, I will repeat them. They do have a role in me deciding on how often I want to follow up these patients. Ultrasound, very rarely in my practice. I'm not sure how many of you would do an orbital ultrasound. But the role of CT and MR is established. CT scan is mostly for assessing the effect of the bones, and MR is for the soft tissues. The indication for CT in my practice basically is for surgical planning, and very, very occasionally if the diagnosis is in doubt. There are several papers, the earlier papers, which kind of divided the orbitopathy into 2 different groups, the type 1 and the type 2, depending upon the amount of fat in the orbits. One was the myogenic variant, another one was the lipogenic variant. Myogenic variant meaning the muscles were very big, and the lipogenic meaning the fat was the majority of the component in the orbit. Now, the MRI scan is mostly for soft tissues, and the advent of the STIR sequence has revolutionized the assessment of thyroid eye disease. Now, STIR stands for Short T1 Inversion Recovery Sequence, and the signal intensities correlate with the disease activity in the orbit. In other words, if the activity was more, the signal intensity was much higher. And there are several studies which have proven STIR sequence to be very effective. One in the follow-up assessment, and two in assessing the response to treatment, especially after steroids or radiotherapy. Now, in my practice, MRI is mostly used before and after intravenous steroids and before and after radiotherapy as well. Now, this is another interesting paper. Jimmy Uden and his team from Moorfields have come up with classifying thyroid eye disease into 6 different phenotypes. For those who specialize in oculoplastics, is an excellent paper to read, where he's kind of divided them into the congestive white eye expansion all the way up to the cicatricial passive phase. All this is important, not in managing, but when we deal with the decompression and other surgeries for these patients. Now, once we have investigated, we've done a CT and an MR, and you want to effectively treat these patients, you should be aware of all the treatment modules which are available for you, because at any given time, you will need to use bits and pieces from each of these different circles. You need to know all the medical options available for you, utilize radiotherapy and surgery if needed. Now, whatever the stage of the thyroid eye disease, there are basic principles that you have to follow. You have to restore euthyroidism. That's the primary goal. Most of the time, this is done by the endocrinologist, so we don't have to deal with it. They deal with bringing down your thyroid function 2 specific ways. One is the titration method, another is the block and replace. Titration is they give you a dose of these anti-thyroid medication, repeat the blood test in 12 weeks or 8 to 12 weeks, see how the response is, and then modify the dosage. The block and replace is where you block the thyroid completely and replace with thyroxine. Depending upon the preference of your endocrinologist, they're going to use whichever method. If for some reason patients can't have the titration or the block and replace, or they develop significant side effects to the thyroid medication, then radioactive iodine is an option. Please remember, those who have radioactive iodine, there is a small group which can have thyroid eye disease, even if they didn't have any thyroid eye disease before. You can manage this by having pre-radioiodine steroids as a small course, and follow them up even more closely. Surgery is always an option, but that depends on your local hospital protocols. Urge smoking cessation. So I almost threaten all my thyroid eye disease patients, if they do smoke, I do tell them that there is a 7 times poorer outcome for their management. And if they do continue to smoke, definitely I avoid doing a number of surgeries for them. I also tell them that whatever surgery we've done for them before, the whole disease can reactivate if they continue to smoke. Selenium supplements up to 200 micrograms a day has been proven to be very effective in managing patients with thyroid eye disease. They don't cause any significant problems. The biggest side effect is they can decrease the amount of vitamin C absorption in your gut, easily overcome by asking them to have another orange. Now, in terms of management, so assessing them into 3 different groups: the mild, the moderate to severe, and the sight-threatening condition. For the mild group, we tend to just treat them with selenium supplements, just lubricants, and they should be okay. Majority of the patients with thyroid eye disease will resolve by themselves. Almost 93 to 95% of them will not progress. It is a small group of 3 to 7% which will progress to the mild, to the severe, and the sight-threatening conditions. So for the more severe varieties where you have the active eye disease, the first drug of choice is steroids, and we kind of reassess them. And the best protocol for the steroids is a 12-week course. And the idea of giving the steroids is to decrease the height of the sinus curve and Rundle's curve. So if we can decrease the amount of inflammation, then the amount of side effects they develop in the plateau phase and the regressive phase is a lot less. And the chances of you needing to intervene will be a lot less too. Now, as I said, the best protocol out there is a pulsed regime with methylprednisolone. You have a whole cumulative dose of 4.5 grams of prednisolone. There's been several trials, and this is the best protocol available right now. 6 weekly infusion of 500 milligrams, followed by 6 weekly infusion of 250 milligrams. Now, I normally give them a dose of 3 and reassess to find out if they have any significant side effects, or if we have to add on steroids with radiotherapy or any other medication. For certain patients, 500 milligrams may not be enough. You might want to start at a higher dose because their inflammatory scales are much, much higher. You can do that, but always remember, if the cumulative dose is more than 8 grams of intravenous glucocorticoids, then the risk of complications is twice as high. The biggest risk factors you're going to get is hepatic toxicity. You should have regular liver function tests done for this group. And if they're diabetics, then their diabetic medication has to be modified. Make sure their blood pressure is also modified. If they do have psychiatric disorders, definitely avoid using 12-week dose of any steroids on these patients. Always prescribe your proton pump inhibitors and bone protection for women. Now, you give them a 12-week course of glucocorticoids and then kind of reassess if all the inflammatory markers assessment is lower, well and good. If they have only a partial response, you have several options. One option is to go for another course of intravenous glucocorticoids. I usually assess these patients in 3 to 4 weeks' time. If the response is adequate, then I continue for 12 weeks. If the response is not adequate, then I will add on radiotherapy or other medications to it. Now, you can go for a second dose of intravenous glucocorticoids if the cumulative dose is not over 8 grams. Radiotherapy is another option. You need to give a total amount of 20 grays per orbit. They usually get it over 10 days, 5 days on, 2 days off, over a 2-week period. Now, oral steroids and orbital therapy is an option for patients who are not willing to go with IV glucocorticoids, or for some reasons can't come in for IV medication. When you give them oral prednisolone, then make sure you still cover them. You still have to take all the precautions with any other steroids. Now, the second line management, depending upon your training, depending upon your exposure, depending upon how well you can follow up the patient, treating with oral steroids along with cyclosporin. Now, cyclosporin is a quite important disease-modifying drug, so please make sure that you have adequate clinical support for this. Cyclosporin can have hepatorenal toxicity and gingival hyperplasia. And you should, if you have any doubt that the patient will misuse cyclosporin, I would recommend that we don't start them on cyclosporin. So when I started my fellowship, the only option was either intravenous glucocorticoids and then orbital radiotherapy. Cyclosporin, we were not sure on whether cyclosporin was very effective or not. And rituximab had just come into the market. And since then, there's been several clinical trials to prove the effectiveness of rituximab. The problem with rituximab is it's expensive. So if you can afford it, or in a health system where you can give rituximab, it is quite effective. You have to give it almost 100 grams, 1,000 grams administered twice over 2 weeks and reassess the response up to 3 to 4 months time. It has an effect on the B cells, and the recent trials have proven that the reactivation following use of rituximab is a lot less compared to glucocorticoids. Now, other medications have also been used: periocular injections, subconjunctival triamcinolone periocular to decrease the activity of the extraocular muscles, subconjunctival steroids to decrease the lid retraction. All those are not used regularly, but those are the different options available to you out there. Now, the current drug which is making a lot of noise is teprotumumab. We know that the pathogenesis involves autoantibodies stimulating the orbital fibroblast. So the antibodies go and stimulate the fibroblasts produce certain cytokines. So if we have a drug which goes and attaches to the protein molecule which stimulates the fibroblast and prevents the antigen from stimulating the fibroblast, then we disease the whole disease activity. So that's how this new drug works. It's still not been licensed to be used in different parts of the world, but it is shown to be quite effective in treatment. I don't have any experience in using this drug because it's not approved to be used in my region yet. Now, other medications people have used, azathioprine, cymexone, and other analogs, they have no proven benefit as such. Now, for those who are going in for exams, this is a good summary. You can download that, and it's a quick fire just before you go to the exam. Now, so we've got medical management. You've learned about radiotherapy, surgical management. So when I started off, it was always about 2-wall decompression, 3-wall decompression, lifting the eyelid up, dropping the eyelid down. With more and more experience, I've kind of recognized that less is more, because the predictability of surgery with thyroid eye disease patients is not as good as other patients for various reasons. Now, in terms of surgery, it's mostly during the rehabilitative phase that you want to do the surgery, but in the congestive phase, there is a role as well. In the congestive phase, mostly if there is an optic nerve problem, you want to do a decompression. The whole idea of doing the decompression is to increase the volume in your orbit so all the tissues can expand and it doesn't press on the optic nerve. And the most common way of doing that was 2-wall decompression, where you do the medial wall, medial floor, and the lateral wall. Now, when I started training, I started doing it through the external approach. But in the last 3 or 4 years, an endoscopic medial wall decompression is a lot more effective and efficient than an external approach. Endoscopically, you can approach them right to the apex of the orbit and you can expand that. Because it's pressing on the nerve, it makes more sense that you decompress the apex. Those of you who do the decompression, doing an apical decompression with the external approach is not as effective as doing it on an endoscopic approach, and it's a lot more efficient. Right now, I link up with one of my ENT colleagues who's a skull-based surgeon and who's capable of doing decompression all the way up to the optic canal, which tends to be a lot more effective and efficient than me doing a medial wall decompression. Lateral wall, again, if you look at this specific case here, doing a lateral wall on this specific case is literally doesn't really do any decompressive work, because you want to decompress right at the apex here. So lateral wall has a small role to play, but not a significant role in the congestive phase. In the rehabilitative phase, yes, there is a huge role for that to play. Now, again, after the decompression, sometimes, depending upon how elastic the eyelids are, the eyelids can come back to its normal position. Like on this lady on her right side, you can see after decompression, the lids have come back to the normal position. But for some patients, the lid continues to remain retracted. You will need to do another surgery for them for the eyelid. So when you do start the decompression, tell them what you're actually aiming to do. All we're doing is making some space in the orbit so that the eyeball can sit back in the orbit. It not necessarily means that the eyelids will drop down. Now, lid surgery, again, in terms of eyelid surgery, it's the lower lid, which is a bit more difficult to deal with than the upper eyelid. Now, the lower lid with retraction, you need to have a lot of spaces. You can either get a hard palate graft or a dermis fat graft from the abdomen. Right now, we don't harvest any graft. I use a material called tutoplast, which is a bovine sclera-like material that the glaucoma surgeons use, and that's very similar to the tarsal element, tarsal plate. You can even get a free tarsal graft from the upper lid and put it for the lower lid spaces and push the lower lid up. Now, they have used a number of other materials for spaces, but my practice right now is to use the tutoplast or a dermis fat graft. Now, upper lid lengthening procedures is a bit more predictable than the lower lids. You can drop the eyelid down by mullerectomy, a levator recession, or a complete blepharotomy. Blepharotomy, again, it's a kind of a modified blepharotomy right now, where we make a full thickness incision through the skin, the levator muscle up to the conjunctiva, but don't reach the conjunctiva, and just leave the eyelid hanging with skin sutures. And the mullerectomy and levator recession is more transconjunctival, while blepharotomy is full thickness. Now, I'm not a squint surgeon, so my knowledge about squint surgery in thyroid eye disease is very, very limited. It's mostly recession rather than resection, and I send it to my squint colleagues who deal with it. And the main idea of the squint surgery is to give you a very good binocular single vision and no double vision in down gaze, and that's the purpose of that. Okay, so that's a very quick bird's eye view of all the problems relating to thyroid eye disease. So that gives you an idea of all the problems that you might potentially face. But I'm happy to take any questions. Hello?
Hello, Dr. Bertie. Can you hear me?
Yeah, go for it.
Yeah. I am Dr. Chandresh Parekh from Mumbai. Very good talk. My question is, before you do any surgery, say in form of orbital decompression or squint surgery, how
Yeah.
long do you wait for the active phase to subside?
So in terms of if assuming the patient is quite active and presuming there is no optic neuropathy, then I wait almost up to 18 months to 2 years to make sure everything is okay. So if there is optic neuropathy, assuming there is red desaturation and the vision is dropping by a line, then I give them intravenous steroids, reassess them in 2 weeks. By 2 weeks, if they haven't had a significant improvement in their red desaturation, I will proceed with decompression straight away. If they do present with 2-line drop, I do proceed with decompression straight away. If their vision improves and the inflammatory markers on the eyes is better, then I tend to wait. If they smoke, avoid any surgery on those patients. I have personally decompressed people with excellent results, radiologically excellent results. Patients continue to smoke and they will have reactivation. And then there's nothing more we can do for these patients. So I do wait for around 12 to 18 months, but depending upon how the response to the treatment is, I will go ahead.
Second question is that any experience with optic nerve sheath fenestration where the optic nerve is threatened?
No, I've done optic nerve head fenestration, optic nerve fenestration only for 3 or 4 times in my career. And all of them were for benign intracranial hypertension, was not for thyroid eye disease.
Thank you.
So there's another question on when the thyroid levels are normal, how do we still diagnose thyroid eye disease? So when the thyroid eye disease is normal, if there are symptoms of signs on the eyelids, then definitely it is thyroid eye disease. If you're unsure, you can have a CT or MR done to assess the size of the muscle. If the size of the muscle is neither here nor there, and if it's just extraocular movements which are a problem, then you can still diagnose it as thyroid eye disease, but I tend to send it to my squint guys saying, listen, as far as the extraocular muscles are concerned, there's nothing much I can do. There's another question on, sir, can you please comment on managing extraocular movement restriction in thyroid eye disease? I'm sorry, I can't comment significantly on that because my knowledge is very limited. I'm not a squint surgeon, but the whole idea of this condition is to have significant or increase your binocular single vision in primary gaze and not have any diplopia when you're looking down. So that would be the principles of it. You don't resect the muscles, you recess the muscles. And when do you actually do the squint muscle surgery? There are, I'm talking about exceptions now, keeping in mind more than 95% of them don't require any significant surgery. There is a small 1 or 2% who will have significant problems with exposure keratopathy, proptosis, and other problems. Sometimes you can do the extraocular muscle surgery and the decompression at the same time if you do have the expertise and surgeons, all the surgeons work together. It's very, very, very rare, but that's not the rule. Children manifesting thyroid eye disease need to be operated early for lid retraction and squint, or do we need to wait till they reach adult age? So I do have a small cohort of patients with thyroid eye disease on children. I haven't operated on any of them. I've always waited for things to settle down, and 80–90% of the time they will settle down without significant problems. You do not have to rush into any eyelid lowering surgery for these patients. It's still, no one has produced a huge amount of papers on this, but I've lost all the chats for now. But my experience is with working with Tim Sullivan, who links up with the Children's Hospital in Brisbane. And so there are quite a few patients with thyroid dysfunction, but very few will develop eye disease and significant problems. Anomaly, can you just put up the chat for me? I can't seem to get the chat. All right, here we go. When thyroid levels are normal, children manifesting general concern is that, do you do strabismus after decompression? That's when, yes, we do strabismus surgery after the decompression. So you will have to decide whether you want to do the decompression first and the reason for the decompression. just because they have proptosis does not mean they need decompression. So there should be a reason why you are decompressing before considering any strabismus surgery. Would you ask for thyroid antibody estimation for managing thyroid eye disease? So that's a question. Yes, I do ask for thyroid antibody levels for, one is to know how active they're going to be. So if they have a very high antibody titers, then the chances of them having an active disease continues to be high. So there are some studies to show that thyroid stimulating antibodies, the antibodies remain stable throughout the course, even when they become euthyroid. For some people, the kind of antibody titers kind of decreases. So if the titers are high, I tend to keep a closer watch on them and follow them up more closely. And I will tell them there is always a chance that you can reactivate. If the titers are low, then I don't need to follow them up as closely. Now, when do you start steroids? There are these patients who suddenly develop proptosis really fast, say a month or two. Should we start steroid systemic sooner for them? Also, in a busy OPD, what classification do you recommend for following up patients' talk? Okay, so when do you start the steroid? So if you have any disease active score, so it's all about assessment. So in a busy outpatient clinic, having the visa score on the UGO assessment will take at least 15-20 minutes. So even if you can't do the visa classification, I would recommend that you do the UGO inflammatory index. That's quite quick. It's very easy to do. You will be able to do it in 5 or 10 minutes. When you start off, it's going to be complicated. Then if there's any significant activity, if there's signs of red desaturation, go for the steroid straight away. Make sure you warn them of the side effects of the steroids before you start them on steroids. Also, it depends upon the specific orbits. So the Caucasian skull, the Asian skull has a nice conical orbit. So there's a bit of space, a bit of time for us to play with. A Mongolian race with a flat, shallow orbits will have less time or less space for it to expand. So you need to be aware of those morphological changes in different racial groups. So for example, for a Mongolian race, they will start off with minimal inflammation, proptosis, before you know they are going to optic nerve problems within a matter of 1 or 2 months. If the apex is nice and if the orbit is nice and conical, then you have a little bit more time. So that's the morphological assessment. So you need to make a call on that. In terms of giving the steroids, reassess them again in 2 to 3 weeks. If there's no response in 2 weeks, you can give them a little bit of radiotherapy and aim to decompress as quickly as possible. Second, another question, lid retraction, but euthyroid. Should we go for thyroid antibody test and follow up for thyroid eye disease? Definitely, if there's lid retraction, definitely go for thyroid antibody test and always tell them the most common reason for lid retraction is a thyroid dysfunction. And if they are significantly affected with the lid retraction, go for the lid lowering surgery as long as there's no significant disease activity. Now, in patients whose thyroid levels are normal, do we still treat them with steroids or do we wait? So thyroid dysfunction has nothing to do with the activity of thyroid eye disease. So whether they are euthyroid or hypothyroid, I would still, if there is active eye disease, I will still go ahead and treat them with steroids. Always remember, if they are hypo, you're going to have more problems. So, you know, we spoke about the titration method where they're giving high dose antithyroid medication, dropping them down. You don't want them to be underactive for too long. If you keep them underactive for too long, then the disease will, the eye disease will progress more aggressively. So you always want them to be euthyroid. That's what you're aiming for. But the hypo is not good news. So always remember that. Is diplopia an indication to start systemic steroids early? Again, if the sign is only diplopia, I would have a stir sequence MRI done. That will give me an idea of how much of inflammation is there in the extraocular muscles. If the extraocular muscles are significantly affected, then I give them steroids. So if there's diplopia, I do the MRI stir sequence and there's not much activity and it's a kind of a regressing orbit, then the role of steroids is not, we can try a short course of steroids, but you're thinking more in terms of squint surgery rather than steroids. So if it's quite active on MRI, intravenous steroids. If it's not so active on the MRI, I would go for oral steroids and radiotherapy. There is a fantastic review on the American Academy of the role of radiotherapy. Radiotherapy is meant to be more effective in double vision, especially for the vertical muscles, not for the horizontal muscles. So yes, steroids and then radiotherapy. What about topical steroids for thyroid eye disease? So if you're talking in terms of topical steroids, just to dampen the inflammation on the conjunctiva, there's very little evidence for that. No harm in trying. If you have superior limbic keratitis, yes, you can try that, but not much role in that. By bringing patient to euthyroid state, what effect will it have on the activity of the disease? So bringing them down to euthyroid state has nothing to do with the thyroid eye disease. So you can bring them down to euthyroid, you can, and they might remain euthyroid, and your thyroid eye disease can still progress. So yes, it's important to bring them down to euthyroid, but the disease progress is not parallel to your systemic thyroid status. So you can be hypothyroid, euthyroid, or hypothyroid, and your disease your eye disease will progress on a different time scale. But remember, hypothyroid is bad. If you're giving, if they are giving radioactive iodine, always remind them to give a steroid cover and keep a closer watch on those who have had radioactive iodine treatment and those who smoke, because they will reactivate a lot more quickly. We have a considerable number of euthyroid patients who have symptoms where the endocrinologist refuses to start any thyroid medication. What should we do? Simple, get another endocrine colleague. So someone who you can talk to. So endocrinologists, they're going to treat the bloods. They're not going to treat the patient. They're going to look at T3, T4, TSH levels. So basically they'll find out what the T4 levels is. And if the T4 levels are fine, they are not going to treat. You don't, as long as they are euthyroid, there's no reason why you need to start them on any systemic thyroid medication. That's up to them. So you always tell the patient that they are euthyroid. That is different to your eye condition. So you may not need any systemic thyroid medication, but they might have to come for follow-up for the eye disease. So it's two different entities. And there's another question. How frequently do you follow up patients in the active phase? So if they are significantly active, then I tend to follow them up once every 4 or 6 weeks. If I've started them on intravenous glucocorticoids, then I see them every 3 to 4 weeks. The first 3 weeks, I will reassess how their response is, and I would have made a call on whether the steroids alone is enough or not. And then I'll plan for radiotherapy. If there is optic nerve compression, then we plan for surgery. So every time a patient comes to me, especially the first visit, I tend to give them at least 30 to 45 minutes of my time. And I tell them every time they come into the clinic, I will be telling them something new. It's not possible for me to tell them everything which is going to happen during the whole course of the disease. So every time they come in, they get something new. If it's an inactive disease, then I tend to show a little bit of disrespect, as in I tend to follow them later and later. If they have high antibody titer levels, you want to follow them up closer. So in my practice, 3 to 4 months is possible. In other people's practice, I'm not sure how that's going to work out. You'll need to work out how often it's feasible for your patient to come for a regular checkup. If they do have active eye disease, then they'd always get an orthoptic assessment every time they come. Will it change every 3-4 months? Not really. But definitely the inflammatory score, you need to spend time with the inflammatory score. If they've had eyelid decompression surgery, that's towards that end of the spectrum. We don't have to follow them up regularly. Sometimes if they've been stable for more than 12 to 18 months, I tend to discharge them as long as they don't smoke. I tell them there's always a chance it can come back again. If there is a problem, come back and see me. If not, you can go home. So that's how I tend to follow up. So patients with thyroid gland enlargement and active thyroid eye disease, surgeon is advised for thyroidectomy. How do you manage the patient? Do you send the patient for thyroidectomy or do you treat them first? So sending the patient for thyroidectomy is crucial. Again, it depends upon what the goiter is doing. If there is optic neuropathy, then I would like to go in first before the thyroid dysfunction. The only problem is the anesthetist will not be happy to put someone to sleep, especially with a thyroid storm. So you will have to link up with the surgeon and see how quickly you can get them to a new thyroid state before you can intervene. So have a chat with the surgeon. That's what I normally do. Chat with the endocrinologist, chat with the surgeon. Always tell them, right, if you're going to operate, make sure you have the replacement regime pretty much ready to go on straight away. And you'll have to give that option to the patient. But the anesthetist will not be happy to put anyone to sleep, especially with a thyroid crisis. I have a patient with euthyroid, but she has active thyroid eye disease. Can I manage her with systemic steroids? Definitely, you can manage her with the systemic steroids. Put her on a course. You can start off, assuming her weight is average around 60-70 kilograms. You can start off with 60 milligrams orally. Plan for radiotherapy as well. So oral steroids with radiotherapy is a good option to start patients. The next one is treating thyroid eye disease important or the thyroid surgery? Which one first? That's a difficult one to answer. As ophthalmologists, we want to make sure that the thyroid eye disease doesn't compromise the optic nerve. But in order for us to do the decompression, we have to put them to sleep. The anesthetist will not put them to sleep if he's got an unstable thyroid because of the thyroid crisis. So you will have to have a chat with the anesthetist as well as the surgeon and how safe it is to put them to sleep for thyroid decompression. How do you convincingly explain to the patient when her thyroid status is normal, but she has got thyroid eye disease? You spend time. The single most important thing for a thyroid patient is time. So you have to spend time. Some people believe you, some people think you are a complete load of rubbish, but your responsibility is to spend time with them and tell them that the thyroid dysfunction has nothing to do with the eye disease. You can be euthyroid and still have an eye disease. They're two different entities completely. And that's important. You have to establish that rapport and that knowledge for them. So 3 things I always tell them right at the beginning: your thyroid eye disease has got nothing to do with your thyroid. You can still have a problem if you're euthyroid. If you're smoking, stop the smoking. Those are the 2 main things I tend to tell them with every visit, especially the first visit. If they can take home those 2 messages in the first visit, then you have won half your battle. When patient goes for thyroidectomy, always have to cover with oral steroids. Not for thyroidectomy, but for radioactive iodine, yes. For thyroidectomy, you don't. In my practice, I haven't given oral steroids for thyroidectomy. For radioactive iodine, definitely oral steroid cover, especially if they have high antibody titer levels and if they have mild thyroid eye disease. You always tell the patient who goes in for radioactive iodine that there is a small chance that whole thing can worsen after the condition. That worsening can happen up anytime from 4 weeks up to 12 weeks. So I always see them 4 weeks after the radioactive iodine and keep them a close watch up to 4 months. Can we start steroids and thyroid medication simultaneously in active disease? Yes, I'm assuming the thyroid medication is about carbimazole or propylthiouracil. You can start steroids just before starting steroids, make sure there's no sign of infection. In my practice, there's a lot of Asians, so we always do make sure there's no a risk of TB. It'll be the same in India as well. Get liver function test and get your weight and blood sugar and blood pressure before you start them on steroids. If there's any, obviously, if there's any psychiatric problems, then I don't tend to stop them on steroids. How effective is the textbook conservative management with head end elevation and cool compress and non-steroidal anti-inflammatories? It is quite effective. The conservative management, yes, I do tell them decrease the salt intake, lie down with 3 or 4 pillows. You will have to understand that there is a significant morphological change going on in the patient's face, and you have to be sympathetic to them because sometimes they come up with minor swelling and you kind of look at them and thinking, it's only a minor swelling, get out of my clinic. But if you do mention that to them, they're probably not going to be very happy. So you have to be sympathetic to them. It does play a small role, whether clinically it's effective or not. The huge placebo effect is that there is a huge placebo effect. So it is worth trying that. When situation not conducive for intravenous steroids, where would you prefer? Which would you prefer, radiotherapy or second line medication? I'm always a radiotherapy fan. The second line medication with the cyclosporin, I've had a couple of patients who've gone off on cyclosporin, and every time the patient doesn't come up for follow-up with cyclosporin, I do get really agitated because they can quickly have problems with cyclosporin, and I don't like that in my practice. So I'm a big fan of radiotherapy rather than second line medication. Now, rituximab, also a second line, and the newer one, teprotumumab, is there. In the United Kingdom, the treatment protocols are funded by local groups called CCGs. In the hospital I work with, rituximab is allowed, so I do have access to rituximab, although I've used that only for 1 or 2 patients in the last few years. I think the main reason why we are seeing less and less acute thyroid eye disease in the Western population is because the endocrinologists are getting better and better at managing them in the very early stages. And as ophthalmologists, we are kind of intervening earlier and earlier. And that's why we're not seeing that many patients who are going in for rituximab or decompressive surgery now. Any other questions? Does radiotherapy work effectively in muscle dominant disease or fat? Radiotherapy does work effectively in muscle dominant disease if you're assuming that the muscles will shrink. They're not going to shrink. They are effectively going to dry up a little bit, and there is enough evidence to say that will help with vertical diplopia. But for horizontal muscles, they're not that effective. But definitely radiotherapy and steroids are effective in managing double vision. So some questions from YouTube. Anomaly is going to ask those questions. Anomaly, are you going to ask those questions? Few years ago, some were using CellCept for TED. Is it still being used? Not currently. We're not. I don't use any CellCept, and it's not been approved in my local CCG. And I'm not aware of people using CellCept in the wider population. Is Anomaly asking the questions from YouTube, Dr. Venkatesh? There are reports of intractable diplopia after decompression. What's your experience? So again, just before decompression, you want to assess what kind of decompression you're going to do. You have a 2-wall and a 3-wall decompression. So we do a balanced decompression right now, a bit of the medial wall, medial floor, and the lateral wall. The important bit is to leave a strut of the floor still intact. So the chances of having any problems or diplopia after decompression is a lot less. Having said that, so if for those who are doing repeat decompression, the orbital fat tends to respond in different ways. Even in the same patient, it responds in slightly different ways. So if you are in a fibrotic stage where the fat has become quite fibrotic, so when we do the medial wall decompression, especially the medial endoscopic decompression, you've taken away all the medial wall and you're kind of incising into the orbital periosteum. If the fat kind of prolapses significantly, then you're going to get a fantastic decompression because the fat just comes in quite well. So one of the problems then is it kind of moves all your extraocular muscles to a new state as well. So they can have diplopia for a short time. For 99% of the people, they'll be fine. So, but there is a small group of people who can have intractable diplopia, and you warn the patient before you do the decompression that that's going to be the case. And if you do develop diplopia, you just have to send it to the squint surgeons to deal with it. And they will not do the squint surgery straight away. They will wait for up to 360, sometimes even 8 months before they can think about eyelid surgery. So what's my experience? In the last 4 years, I haven't had any, and as luck would have it, from November, I've got one patient with double vision, but she's had a mild active disease, and she started to smoke for whatever reason, and her disease just went significantly worse. We decompressed both her orbits, and she's fine. She's got her color vision. She's got back to 6/6 vision, but she has got double vision. Um, she's happy just to patch one eye. She will have squint surgery sometime in the future, but she's still on oral steroids for now. So that's my latest experience. So it does happen. You have to be careful of that, and you will have to warn patients that that is a possibility. Intractable. So if you are doing a balanced decompression, then the chances of diplopia is a lot less, but it is a possibility. You have to be careful with that. See your WhatsApp. Okay. I'm just going to switch on my phone because apparently some people have been.
Okay, thank you.
Advantages of combined extraocular muscle surgery and decompression surgery. There are more disadvantages than advantages. I would prefer to do the decompression and the extraocular decompression first, let everything settle down, and extraocular muscle surgery. For very, very occasionally, if there's so much of proptosis where the globe is partially subluxated and there's hardly any Bell's phenomenon and the significant corneal exposure, you can't close the eyelid down, then you can do that. That's very, very, very rare. Those are exceptions to the rule rather than the norm. I wouldn't put any advantages to that at all because there are risks with decompression surgery, there are risks with extraocular muscle surgery. So there's more disadvantages than advantages. So I wouldn't put that as an so let's see on WhatsApp.
Sir, you're able to hear me, sir?
Oh yes, you're on. Go for it.
Sir, apologies, sir. I was not able to unmute my mic for some time.
Okay.
So there are a few questions in YouTube chat. Ms. Shabnam Singh asks, a euthyroid patient with significant proptosis even after medical therapy, do you consider orbital decompression for cosmetic reasons?
So the question here is about decompression for cosmetic reasons. Yes, I would consider, as long as the disease is inactive, and make sure you have a frank chat on what the decompression is going to achieve. So if the patients believe that the decompression is going to make them how they were looking 15, 20 years ago or before this disease process started, that is not going to happen. Decompression is not a panacea for all their lid problems, for all their medical problems. Decompression is to make space in the orbit and to push the eyeball back so there's less proptosis. So that does not mean that they will not need eyelid surgery. That does not mean that they will not develop diplopia. So you have to be very clear on what the surgery will achieve and what they want, what the patient wants the surgery to achieve. So make that very clear. If for some reason you feel that you are unable to fulfill the patient's expectations, you're much safer not to touch that patient because invariably they will remain unhappy. They will have constant problems, or they will find out newer problems for you to deal with. So if you have any doubt on any thyroid patient that they have unrealistic expectations, please don't do surgery on them. and I follow that policy even now. People send patients to me for different opinions, and if I have any doubt that their expectation is unrealistic, I just tell them, I'm not the surgeon for you. You might want to go see someone else.
And there's another question on can you share your experience of thyroid eye disease in pediatric age group?
So I think we've had that discussion now. I don't have a huge cohort of patients with thyroid eye disease on youngsters. My youngest patient is 11, and my oldest in the pediatric age group is around 16. Total of around 15 or 16 patients in total. All of them, none of them have had any surgery. There's been one or two where I was itching to do the surgery, but I've just refrained myself from doing them. And I'm happy that I've refrained myself from doing them. None of them have had significant inflammatory markers. Most of them will have an inflammatory score of around 4 or 5. I think only one person was on 5, but it was more of a white eye, more proptosis, more lid retraction. But as they went on to teenage years and when things have settled down, their retraction has been less prominent. Keeping in mind that this is more common in women, women like to have a much bigger palpebral aperture than men. So don't drop the eyelid down. They like to look beautiful. So they want to have a little bit of eyelid retraction. But if there is corneal exposure, then that's a different story. So, but in terms of decompression, definitely not. In terms of extraocular muscle surgery, I haven't seen any of my patients move into that category.
And one last question is, what are the general measures that you would advise for a patient with thyroid eye disease, apart from smoking cessation?
General measures, it again depends on how educated the patient is and how motivated the patient is to deal with all things. Selenium supplement is definitely useful. The evidence is only for 6 months to mild to moderate disease, but I ask them to continue with the selenium. Keeping with 2 or 3 pillows up can decrease the amount of periorbital edema, but that's as much as it's going to go. Now, lots of topical lubricants for patients and topical steroids occasionally. There's another question which just popped up. Do you have a different threshold in initiating treatment for men versus women? Yes, I do. Keeping in mind the disease process is more common in women than in men. But for men who develop this condition, usually it is a lot more severe. So again, smoking is a huge factor. If they smoke, I tend to avoid operating on them because I've been sorry that I've operated on a few patients. But in terms of threshold, would I operate earlier on men than women? I don't think so. But I'm always aware that a man's eye disease progresses a lot more quickly and faster. But you also have to take into account the type of socket or the orbit each one has. So if it's someone with a Mongolian skull, even if it's a lady, I would operate on them earlier because I know that there's not enough space on that orbit to expand into. Any indication for muscle biopsy in thyroid eye disease? I have not done any muscle biopsy in thyroid eye disease, so I would have to raise my hands and say I don't know.
Thank you very much, sir. It has been an extensive and comprehensive lecture on thyroid eye disease, and you answered all the questions very patiently. So thank you very much, and we are looking forward to more lectures with you, sir.
Thank you very much. Thank you, Dr. Venkatesh. Thank you to Arvind Eye Hospital.
Thank you, Bertie. Much appreciated. Your talk, also the discussion which was following. the talk. I think it would have definitely practically benefited a lot of people. And we had a very good attendance also. Thank you and take care.
Thank you. Stay safe.